Good evening, and thank you for attending ACAM's webinar with Dr. Ahvie Herskowitz presenting Plasmapheresis, the science, clinical impact, and lessons learned in an integrative cancer care treatment center. This webinar is approximately 50 minutes and will be followed by a question and answer session. Attendees are encouraged to submit questions throughout tonight's presentation using the Q&A box located at the bottom of your Zoom screen, and we will address them at the end of the presentation. Registrants can expect to receive a recording of this presentation via email within 7 to 10 business days. I would like to introduce Dr. Ahvie Herskowitz. With over 4 decades of experience in anatomic pathology, cardiology, immunology, integrative oncology, and regenerative medicine, he brings unique insight to the art and science of healing and is one of the most senior academic and anti-aging physicians in the United States. Dr. Herskowitz currently serves as the president of the American College for Advancement in Medicine and is the founder of Anatara Medicine, a multidisciplinary medical center in San Francisco, where his work focuses on advanced approaches to integrative cancer care in complex chronic illness, immune system modulation, and regenerative and preventative medicine. With that, I would like to hand it over to Dr. Herskowitz. Welcome.
Thank you, Shaylin. Thank you, Daniel. Thank you, everyone, for coming. I just got back from Japan, where I gave a similar talk on the use of plasmapheresis as an anti-aging tool. I think that the question that I was trying to answer when I decided to get back into plasmapheresis was whether we could remove a whole bunch of toxins in our system, in our plasma, at the same time rather than one at a time. So we're going to focus on cancer care per se, but everything I'm going to say today is related to its approach to anti-aging or anti-inflammatory modulation. I also came back from Paul Anderson's naturopathic AAMP meetings where I gave a lecture on this type of a lecture, and Dr. Paul Savage gave a plasmapheresis lecture on the use of apheresis or plasmapheresis or TPE for preventing illnesses over time. And this is one of his slides that I'll be using today to sort of present the picture that and in particular post-pandemic, we have a lot more environmental toxins to deal with, which are overwhelming our system. Perhaps that's due to the spike protein, perhaps not. We don't know for certain. But right now, post-pandemic, our cancer care and our aging approach, anti-aging approach, has to be a bit different and more elegant. These are slides again from Dr. Savage, and this is clear to every ACAM member. I'm sure of that. That while most cancers are some cancers were felt to be genetic, the majority, overwhelming majority, are related to environment and lifestyle. We have a reality that our overall cancer death rates haven't significantly increased, but the diagnosis is prompting investigations into potential causes and risk factors. And the hypothesis about this in younger adults is that our overall toxic burden has increased since the past decades, but certainly has been accelerated during the post-pandemic era. We have a variety of forms of toxins. We are all familiar with mycotoxins. Toxic metals is ACAM's gig for many decades. Pesticides, herbicides, and so on PFAs, phthalates, BPAs, and now in the lay press, the all the explosion of information regarding microplastics. The question that we'll try to answer today is whether apheresis or plasmapheresis or TPE, they're all the same thing, is a reasonable strategy to use to get rid of most of these toxins at one particular time with one therapy, with one filtration therapy. Toxins are everywhere. We all know that. We now are doing total tox screens on every patient for this particular reason. They're listed here. They're in the food supply. They're in the air we breathe, and they're in our bloodstream for certain. Um, on the microplastic side, this is again, I think, a final um, slide from Dr. Savage's AAMP lecture. We also have a lot of microplastics in the brain. Our toxins are lipophilic. Our brain is a concentration of lipids. And so we have microplastics in our brain in addition to other toxins. But also, I remember, if you recall, I'm a cardiac pathologist as well, and we can find microplastics in the blood in patients with stroke and sudden cardiac death. Again, here's a listing of all the toxins, just to make the point that most of our diseases are related or attributed or at least associated with toxin exposure, ranging from cancer to cardiovascular and neurological diseases, which are all the diseases of so-called aging that we're trying to address in our practices in the most productive way possible and the most efficient way possible. Dr. Paul Anderson, one of the leading naturopaths and educators, gave this slide at his AMP meetings a few weeks ago, and they're notoriously difficult to get out of the body quickly. And that's the premise of the use of apheresis, whether or not we can get rid of these toxins more quickly than doing them one at a time. So, what are global strategies we've been using as ACAM investigators or ACAM practitioners that may have a more of a global impact in late stage cancer? Well, the concept of hyperthermia is been useful throughout the world, but most of us don't use hyperthermia in our practices. Concepts of targeted vaccines may have global impact on tumors versus normal cells. Therapeutic apheresis is certainly one of the potential areas of research that needs a lot of attention. Lasers and high frequency ultrasound. And of course, lifestyle is on the bottom separately because that always has a global impact. But the point here is going to be focusing on therapeutic apheresis as a global solution or global possible solution for late stage, even for late stage cancer patients. So in our cancer care tools that we have in our clinic, we do run other modalities on a regular basis. We use IPT, we use the Weber laser system, we use all forms of IV therapies, whether they're from the US or Germany. We use macrophage activating factor from Japan. We also reset the parasympathetic sympathetic tone with stellate ganglion blocks. And we use all the other systems listed below, cancer vaccines and SOTs, and so on. So this is an old practice, obviously bloodletting, but the newer forms of plasmapheresis are more digitized as they were compared to the last time I had a machine in my office, which was pre-pandemic. Then the pandemic hit, and a lot of the machines were stuck in customs, and there wasn't an adequate supply of machines, of plasmapheresis machines, which is now no longer a problem. So that's not an issue any longer. This is the machine that we use. The hypothesis is, can rapid detoxification of the plasma block the proliferative signaling in the tumor microenvironment, specifically for cancer? This would be similar to the hypothesis, can rapid detoxification of the plasma block proliferative inflammatory signaling on the aging side? This could be similar. So in the center, you see the cellular terrain. We have to we have to drain the swamp, so to speak, and this is the purpose of doing this type of a strategy or deciding whether this strategy is right for your practice or not. So, what is this? Therapeutic plasma exchange removes and separates the blood elements, red cells, white cells, and platelets separately to the plasma. The plasma undergoes the filtration and then gets discarded while the platelets, white cells, and red cells are retrieved back again back to the patient. So the plasma gets filtered, it gets discarded, it gets replaced typically by albumin, and that's the physiological fluid that's typically used for replacement. And then the patient gets back his or her red cells, white cells, and platelets. Here's a typical patient, and in her left arm is the outflow into the machine. The filter is not seen; it's inside the machine, and then it flows back. The red cells, white cells, and platelets eventually, and then the albumin gets uh, placed back into the patient vis-a-vis her right arm. This procedure typically takes 1.5 to 2 hours. Maybe some really quick, great vein patients can be a little bit faster than that. So, what have we've been using apheresis in clinical practice for now, ever since I was trained at Johns Hopkins 40 plus years ago. We used it for lipopheresis for patients with genetically elevated cholesterol levels, but we use it for all these variety of diseases. Most of the hospitals, big hospitals, have apheresis devices for autoimmune and immunological diseases. TTP is the most common life-saving treatment, although myasthenia gravis and all the renal immune diseases are common. But now, relative to where we are today, post-pandemic, we have to look at whether or not there's a place for apheresis for diseases of cognitive decline. There are publications I'll show at the end of the lecture today that show that cognitive decline can be reversed, at least temporarily, for certain with apheresis. And we'll need to investigate the use of this technology for long COVID patients, advanced cancers, and other chronic illnesses. One of the differences between this and EBOO is the amount of volume that's taken through the filter. This has 1 to 1.5 plasma volumes. The calculation is dependent on lean body mass as well as hematocrit. And then the question is, how many procedures do you need? Does one need? That's a case by case basis and deserves a lot of discussion and questions. I think most of us wouldn't proceed with apheresis to do a single procedure only to check whether the vein access was good enough. And most of us wouldn't use it unless we would have a series of three. I had a series of two done years ago before the pandemic, and I'll show you what happened during that procedure for myself. The duration of therapy is interesting. Under life-threatening conditions in the hospital, it could be done every day. Usually that's in very seriously ill and anesthetized patients in the intensive care unit. But here in outpatient setting, I think the majority of patients would get it weekly, if even in intensive situations, or sometimes we would use it twice a week, but that's under conditions of urgency. We use exclusively 5% albumin as a replacement fluid. You may get 2 liters of plasma out and then take 4 bottles of 500 cc of 5% albumin as the best choice. We don't use saline, we don't use fresh frozen plasma or cryopure plasma. We get good results with 5% albumin, but all these are choices that have been used in the past. So this is the issue for living longer but sicker. Of course, this is going to focus a bit more on cancer than simply aging, but our life expectancy um, has been associated with chronic illnesses. I just flew back last night from Japan, where I gave the same type of lecture as as a post-pandemic anti-aging approach. But there they live 5 to 7 years longer than we do. And so we're 49th in the world now in terms of life expectancy. And not only the Asian countries, but also European countries outlive us by 5 plus years. So our terrain is perhaps worse than others in the developed world. We know we have a great deal of mold and fungi, heavy metals, pesticides, forever chemicals, microplastics. We also have a great deal of patients that also have Lyme and co-infections, viruses, and so on. And looking on the right side, um, almost everyone that we measure spike protein antibodies has high levels of spike protein antibodies in their blood. And of course, with cancer patients, they have oncogenes, and then they also have signaling molecules that support senescence or support pro-oncogenic development of senescent cells into tumor cells. These cell danger signaling molecules deserve an hour of discussion, another lecture perhaps, but all these pro-inflammatory and anti-repair signaling molecules, which many of us are living with on a constant basis, or we're stuck in this old danger signaling milieu. And this is one of the major problems that we all have seen in a majority of our patients with long COVID and with cancer. Our pH is off, our lymphatic and vascular systems are not working well. So on the autoimmune side, this has been working for decades on this. The apheresis has been a, um, a very well described modality for almost all the autoimmune states, whether it's anti-nuclear antibodies, anti-phospholipid antibodies, and now it's becoming more relevant in our post-viral autoimmune states, post-COVID states. Of course, as a cardiologist, I am most familiar with post-viral myocarditis, and we all know that the COVID virus is cardiotropic and is producing both acute phenomenon like sudden death or pericarditis or myocarditis acutely, but also sudden death in an autoimmune state later on, and what we're seeing today. But the the pro-inflammatory milieu that this produces on the autoimmune side is uh, similar to those that found in patients with chronic fatigue or Lyme disease that we're all familiar with, or mold intoxication per se. So these are not specific for one disorder. They're more ubiquitous actually right now in our society. So the older folks are just worse off. They have more pro-oncogenic factors. They have more senescent cells occupying their tissues and their blood elements. The 80% of the population in the United States has metabolic syndrome. The adult population has metabolic syndrome. We have depressed mitochondrial function and increased protein folding that isn't repaired at night successfully every night. So we age perhaps ungracefully. So the question is, what can we do about it in an efficient manner if we have the tools? So what's in the plasma? Uh, this is um, this is a cartoon that's showing the tumor microenvironment. The pink small cells in the center are collections of tumor cells which are undergoing mitosis. The immune cells surrounding them, the dendritic cells that surrounding those, the cells that are being recruited from the blood supply, and these little dots are supposed to represent exosomes or extracellular vesicles that are communicating both from the immune system back to the tumor microenvironment, and more importantly, from the tumor microenvironment, trying to recruit their own population of neighbors into the tumor microenvironment and becoming larger and larger tumor masses because of that communication. And it's these factors that we're trying to get rid of in the plasma at, with the apheresis. So overall, the immune system gets overwhelmed. We have cellular senescence, which is uh, sine qua non of aging, inflammaging immunosenescence, cellular senescence, immunosenescence, and then ultimately where the majority of us, if we live long enough, may develop a high proportion of patients may develop cancer. So this slide shows how we go from youth to adulthood to memory to from naive T cells to memory T cells, and then in the setting of immunosenescence and the setting of cellular senescence, we get the exhaustion of T cells or this or the overall exhaustion, T cell exhaustion that is being now described by the immunologists around the world as part of this overall exhaustive state that we're putting ourselves in. The questions are, how can we release this? So this is a cartoon of the tumor microenvironment. It's a complicated system. One of the fascinating parts of this, as we all know, that we can measure circulating tumor cells very, very early in the tumor progression stage, even before we can identify a tumor in the MRI or the CT scans, where you have to have three plus millimeters of a tumor. You can find it in the blood first, and the reason is because of this cartoon is trying to show that the tumor microenvironment, even in a microscopic tumor, is already has its own blood supply and is communicating with the blood. They have immune cells, stromal cells. There's a matrix. There's an entire universe in here that has to be teased out and understood. And it also communicates with the plasma of the patient. This, I think, is too complicated a slide to go over in detail, but the tumor microenvironment is communicating with T cells, monocytes, macrophages, dendritic cells, and NK cells. These are all can be identified within the tumor microenvironment, and also are communicating with circulating cells of the immune system in this level of complexity that is hard to wrap your arms around, and yet this can be found in a tumor that's microns in size. Then when you deal with the tumor cells within this tumor environment, the the tumor cells themselves are acidic. The environment itself is acidic, with the middle bullet, the accumulation of lactic acid and poor perfusion leads to extracellular acidity compared to the normal 7.2 to 7.4 pH in the normal tissues. But interestingly enough, inside the tumor cells, the intracellular pH tends to be neutral and alkaline, giving the tumor cells some level of advantage of survival versus the normal stromal cells, while they remain stunned or senescent or suppressed. And why does this matter? This promotes acidic extracellular pH, promotes invasion, metastasis, but also immune evasion, and the selection of aggressive clones. It also is a promotive environment for cloaking proteins like nagalase that we measure in the blood of these patients that can cloak tumor cells as well as cloaking mold and Lyme organisms and other viruses and parasites. So how do the tumor cells constantly seem to be taking advantage of their surrounding microenvironment, and why it's so important to have a strategy to take the microenvironment on full blast and concentrate on it and concentrate on the way it communicates with the macro environment, because this is the way it co-ops nutrients. It's like tumor cells are like parasites, and they can block immune surveillance and host responses. All of these have signaling strategies that have been used by tumor cells for as long as we know tumors exist, versus the strategy that we're trying to prevent metastasis and curtail tumor growth. But right now, at this point, with even the concept of turbo cancers, this system on the left side, co-opting nutrients and blocking surveillance, is taken to a new level. This may be directly related to the spike protein circulating um, and and taking over the system, co-opting even further our ability to deal with these signaling molecules that promote growth of the tumor cells and are going against the immune systems that are blocking them. So one thing that would be interesting to identify is whether you could have PD-L1, these inhibitors of programmed cell death, to measure whether apheresis in and of itself is capable of reducing PD-L1, and PD-L1, and therefore you could reduce its impact on being immunosuppressive. Um, and the answer to that is this is exactly what has been shown to happen with plasma exchange, in this case in immunotherapy refractory melanoma in a phase 1 trial, but this has been repeated in multiple systems, where the plasma exchange reduces PD-1 activity and PD-L1 activity. Plasma exchange clears and these signaling molecules are produced by tumor cells, as we all well know from checkpoint inhibitors, positive effect on tumor growth, but they're also inside extracellular vesicles or exosomes. So the tumor cells produce exosomes, and the exosomes are contain information that suppress the immune system, information that promote cellular growth of the tumor cells, and they're inside these extracellular vesicles, which are typically lipid bound. So this is a tough slide to read, but these are the classes of molecules that are captured in total plasma exchange. They're all the inflammatory mediators, immune proteins are the ones that we've been using apheresis for decades. The checkpoints, soluble PDL1s in extracellular vesicles. We've used it in the past. I've used it in the past in genetic disorders of lipid metabolism with very high cholesterol levels, uh, protein metabolites, environmental pollutants, metals, and pathogen associated molecules. These are all the types of molecules that are captured, and now it's more likely than not that it's also capturing the microplastics. There are publications coming forward now, which have been in preprint that I've seen that show microplastics are captured as well as the 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 as well as other nano molecules. I think I can delete this, but this is where evidence is high for autoantibodies and immune complexes. We all know that the renal folks in the hospital who run dialysis also run these apheresis devices in the hospital. But as outpatients, we would be interested in whether or not it can take out pro-inflammatory cytokines and acute phase proteins, and PDLs, whether it can take those out for cancer patients. Their moderate information with regards to the forever chemicals. There's strong evidence that we can capture mycotoxins and nanoplastics and so on. So again, it's the same cartoon as I showed earlier. And if you can identify and deplete the plasma of oncogenes and pro-inflammatory cytokines and chemokines and senescent plasma constituents, heavy metals, mold, spike proteins, fungi, and viruses, you are reducing the load of pro-oncogenic forces in the body at the same time in one therapy. So what's been found to be in the TPE filters, a lot of the evidence suggests that mold and heavy metals, sort of like EBOO, inflammatory molecules, microplastics are now going to be published in the near future, but that's been identified in the apheresis literature. The spike proteins have not been identified as, and I'll show you in a minute how they have been identified in EBOO patients, in EBOO blood filters. But the oncogenic signaling molecules, the PD-1s, have been identified. So this has been taken from a lecture by Dr. Robin Rose, who looked at EBOO samples in 20 patients and showed that the spike protein and toxin-like proteins can be identified in the EBOO filter. I think this is still, in my mind, controversial. It has to be repeated, both for EBOO and for apheresis, but this would be an astoundingly important feature. We now have augmented N-acetylcysteine or augmented NAC to reduce the effect of the spike protein effect in the body itself by stopping the replication, but in this case, it would reduce the overall load in a more efficient and rapid fashion for patients, particularly with turbo cancers. There's also a concept of tumor-induced exhaustion, and this produces further effects on T cell telomeres, which then puts an effect on T cell mitochondria. And when you damage the mitochondria, they talk back to each other and they program the cell to shut down and become exhausted. So then this is a way of the spike protein to also have an effect in all the other chemokines, cytokines, and molds and so on to shut down the immune surveillance system, which we can measure by surrogate measurements by measuring the total natural killer cell population. So this is just a pictorial of the nucleus in the center in the purple, with the green being mitochondria. It's just to show that, and then to show this particular um, publication where PDL1 positive extracellular vesicles or exosomes are much higher in the melanoma patients than they are in the control patients. And this is how melanoma cells evade the natural killer cell population that then cannot train T cells and cytotoxic T cells to attack the tumor cells. This is one of the most the immune sensitive tumors that we have, these melanomas. And if we can get past um, this gate, then we were able to attack the melanomas much more efficiently. Here's another group for the pre and the post on the left side. This is the pre-PDL1 uh, levels in the blood. The post is post um, plasma exchange, and you can see the dramatic decrease in blood PDL1 levels in patients undergoing apheresis and with a variety of different cancers. The treatment on the right is progressively lower and lower as treatment days go by in that particular patient. There are also extracellular exosomes, EVs, as we call them, that can be found in any given cancer. And these are the tumors that are progressing are producing more of these information packets for intercellular crosstalk as they evade the immune system and they progress further. So these TEX molecules actively suppress pathways in the immune system to evade the immune system. So you have these exosomes on the bottom that are produced within tumor cells, and these so-called microvesicles or exosomes are produced that way. And then they're very complex um, packages of information. It can contain proteins, nucleic acids, their own RNA signaling. They can have very precise um, ability to identify these exosomes on the surface ligands, and they can be very sticky. They can stick to any cell type that they wish, and that's how one of the ways that tumors migrate and tumors can metastasize. And they've been studied in patients with different types of cancers. They have signatures on their surface that are distinct, and they correlate with the development of cancers and responses to therapy. So this is a new technology that will be available to us in terms of monitoring cancer therapy, monitoring cancers themselves, monitoring the difference between right now all we have is circulating tumor cells or CTCs to monitor patients, but we'll be able to derive whether certain CTCs are more dangerous than others, more stem cells that are more tumor stem cells that may be more dangerous than others. So what happens when you do a pre and post TPE? Albumin doesn't change because it's a straight recovery with the amount of albumin that you take out versus put in. It tends to decrease C-reactive protein dramatically in those patients that have an inflammatory state. The D-dimer as a coagulation marker doesn't change. The ferritin, which is this is the average ferritin. Oh, this is a unique patient, sorry, is very commonly reduced dramatically. So as a as a pro-oxidative marker, it's markedly reduced. And then the pattern on the right side, which is flipped incorrectly, it started at 139, it goes down to 80 for that patient. So overall, the lipids dramatically drop dramatically after a TPE therapy, but so do the inflammatory molecules. All the lipids go down, ApoB. Again, this is another patient with C-reactive protein goes to less than 1. Ferritin goes down. HDL goes down as equally to LDL and equally to total cholesterol. LP little a goes down. All the different measures of lipoproteins go down. On the immunoglobulin side, in this particular patient, there was no change in IgA, IgG, or IgM, but we do see patients like this whose IgG levels, immunoglobulins level go down fairly dramatically, and this is the basis for why most of us are now giving IV, IV immunoglobulin after the TP therapies, and this is how it's been done in the hospital for decades. Um, I used to have problems giving IVIG to patients decades ago when we used to push it, and now we're giving it slowly in IV drips, and our adverse event rate has dropped dramatically. So now we routinely want to give IVIG after each of the TPEs. And this is just a leukapheresis patient we just did with CLL. The p-value was obviously too low to have leukocytes pheresed in the hospital. Started at 61,000 and post the TPE went down to 27,000. This is a 60% drop, which is common and commonly to be expected after a single leukapheresis. But and then in terms of the mold immunity, the C4A level in this particular patient is reflective of the what's commonly seen, and that is you have an elevation of C4A, and then it goes down dramatically with the plasmapheresis. We don't have long-term follow-up on this yet, so we'll have to watch and wait and see if the immune responsiveness of the complement cascade to mold goes down with the reduction in mold that we see in the urine. I think we've done this before, so we don't have to belabor the point of the massive communication that this tumor microenvironment, even before you can see tumors anywhere on imaging. This is all could be microscopic or all found as we have a patient today who has ulcerative colitis and had a routine colonoscopy and it picked up a microscopic adenocarcinoma. This is this is what's going on in that cluster of cells that the center of which are tumor cells communicating and trying to co-opt nutrients from the environment into their uh, immortal states. So, what did we? This is a difficult patient with a Mullerian cancer of in the uterine from the uterus, but and metastasizing to the neck and the lymph nodes. I wanted to show this simply because after her first TPE, the ultrasound changed dramatically from the image on the left side, which is anechoic, basically. There's no echo for the majority of that enlarged lymph node over after the first TPE into a lymph node that is similar in size, but is now echoic and now has a some form of connective tissue that's emerging in this one. So what we're envisioning here is that there's been a rapid aggressive change in the lymph node architecture, perhaps fewer tumor cells and more connective tissue. This is what you normally see with EBOO, and you see the same thing after TPE. This rouleau formation on the left, and with a dirty microenvironment to the plasma, and here is the post-TPE dark field microscopy, which is clean as a whistle. This is what you'd expect. Here is an interesting patient with squamous cell carcinoma of the tongue, involving the mandible, involving lymph nodes in the oral cavity. On the left, you see the tumor mass itself. After the first TPE, the tumor mass in the center decreased fairly dramatically. There is a lesion in the posterior aspect behind the molar that was not viewed in the first slide, in the first image on the 18th. 4 days later, you can see that there is some irregularity there as well. And then on the 14th, the month after the original, after a series of TPEs, the tumor mass continues to decrease in size, although again, we're not running an experiment here, only using apheresis. We're using other modalities as well. And right now, at this point, the tumor markers are fairly benign, but we have to have long-term follow-up for cases like these, which we don't have yet. So again, the you have we don't have this is not relevant per se for cancer, but C-reactive protein goes down, the stem cell proliferation goes up, pro-inflammatory cytokines go away, and anti-inflammatory proteins are increased. But this is generic for any patient undergoing TPE, and this is the anticipation. All of these have to be quantitatively documented in larger populations undergoing our types of disorders that we typically see, which again would include chronic fatigue patients, long COVID patients, and post-inflammatory patients. We cannot answer this question definitively. All we know is albumin, IV albumin has been around for many decades. It theoretically can contain spike proteins. It is heat treated, and it's very unlikely that a spike protein can survive. No viruses can survive, and no organisms have ever been transferred. But in fact, until we take our albumin and measure in a coherent laboratory that can measure spike protein on a reproducible basis, I wouldn't be able to say definitively that it doesn't contain spike protein. This is what it looks like, a TPE from a stage 4 cancer patient. You can't see the difference in colors, but it looks almost brown rather than the normal light color of albumin. You can see the colors better. This is a patient with advanced stage 4 bladder cancer with high levels of heavy metals. And I think that explained the color changes over his first and second TPE. These are a combination of different types of patients. Inactive autoimmunity looks clearer than active autoimmunity, which almost has a milky quality to it. and the importance of the one on the left corner, cognitive decline. This has been already documented to be a therapy for cognitive decline for even moderate dementia, moderate Alzheimer's disorders, which I can show you in a minute. But this is me years ago, and it almost looks like I have a goldfish in my plasma, and that was an interesting. Let me see. I'll do it again. You see this waviness. This is a blob of fibrinogen and fibrin and myeloperoxidase that existed in my plasma at the time that was removed with this second TPE that I had done once on a Thursday and the next one on a Monday. So experiments in humans show removal of these factors in the left corner, and most of the patients don't complain of illnesses or Herx reactions to the TPE. In fact, it's pretty it's pretty adverse event free, and you have to apply a systems biology approach to study the tumor microenvironment, and actually treating tumor patients requires a system biology approach. And so overall, TPE for cancer is safe. You have an immediate reduction in inflammatory markers, transient reductions in lipids. The lipids come right back in a week or two afterwards. Transient reduction in immunoglobulins, for which we typically give IV immunoglobulin. There's stabilization of tumor size and pain. We don't have the appropriate level of long-term follow-up that I would anticipate having 6 months from now. There is changes in the appearance of the lymph nodes, and the literature does demonstrate reductions in the circulating PDL1s and the PDL1 exosomes. I did want to mention before I sign off, I'm 2 minutes over, but this has already been documented that in studies in 2020 and 2022, these so-called AMBAR studies, the Alzheimer management by albumin replacement studies, that showed that in the somewhat 500 some odd patients that you could reduce the cognitive dysfunction using the standardly validated uh, um, baseline cognitive function measurements. So you can do a great job and have a cognitive decline faction in your practice with this. So these are the pro-aging inflammatory factors that can be identified in the plasma, that all relate to aging. And I wanted to end with that because the next in the next months ahead, we'll have data on this on our aging patients. So the young physician starts with 20 drugs for each disease. And I've shown this before. The older physician ends life with one drug for 20 diseases. And that's what we're all looking for. We're looking for technologies and supplements and any methodology that we can use on multiple disorders. Thank you.
Wonderful. Thank you so much, Dr. Herskowitz. We do have just a couple of quick questions here. Where is the best place in the US to go for TPE for general anti-aging and detox?
Well, there are only a few locations now, but there are two groups. One is I think MD Lifespan, I think it's called, Dr. Savage and Dr. Pamela Smith presented at the same meeting I presented at. I use a different device, a device that was patented by Dr. Kiprov, Kiprov, who's considered to be the father of apheresis in the United States. He has his methodology. I use his. I had his device in my office 5 years ago. There's a few groups in LA But it's just the technology is emerging in the outpatient setting. So you can contact me and I'll tell you how to get in touch with with the group that I have, or you can contact Dr. Paul Savage or Dr. Pamela Smith to look at MD lifespan, which is a slightly different technology, but using the same principles.
Okay. And then can you share with us what is typically the cost?
Well, I think the cost ranges in the United States from 5,000 to $8,000 a procedure. It's packaged differently. Typically, you'd have a package of 3 to 6 of these. For the cognitive decline, it was a series of six over 6 to 12 weeks. And you'd have a package deal, so to speak. Some patients like to see one of them, and it would typically cost between 5 and 8,000. I don't just do the apheresis. I do apheresis and then give supportive IVs afterwards. So there's an IV stack that I give after the procedure, and actually patients have an entire, you know, stack of labs done before. But that's the average in the United States, and there is a European groups that give you back your own plasma that's been filtered, and we don't have that in the United States. But that's a typical amount.
Okay, wonderful. Thank you so much for taking the time to be here tonight, especially after you just got home from a trip from Japan. We appreciate it. Wonderful information. And as a reminder to everyone, we will send this recording out within 7 to 10 business days.
Thank you. Good night.
Thank you. Have a good night.